Hello, my name's Dr. Alan Kerry and welcome to another podcast from South Essex GP Training website. With me today I have Dr. Sunil Gupta and we're going to talk about patient safety. So Sunil, what does the evidence tell us? How widespread is the problem of patient safety within health services?
So this is a very significant problem. In terms of the evidence and the research, in 1999 the US Institute of Medicine published a report called To Err is Human, which said between 44,000 and 98,000 people die in United States hospital annually as a result of medical errors. In 2000, the Chief Medical Officer of the National Health Service published an organisation with a memory which estimated that adverse events in which harm is caused to patients occur in around 10% of admissions, or at a rate in excess of 850,000 a year, and cost the NHS an estimated £2 billion a year in additional hospital stays alone. And the studies of medical records in many countries throughout the world suggest that 8 to 12% of hospitalised patients suffer one or more adverse events.
Tell me about Leape. What did Leape say about patient safety?
So he's really viewed as the father of patient safety. And in 1994, what he said was the professional cultures of medicine and nursing typically use blame to encourage proper performance. He said errors are caused by, according to this culture, errors are caused by lack of sufficient attention, or worse, lack of caring enough to make sure you are correct. But what he said, in reality, many errors are often beyond the individual's conscious control. They are precipitated by a wide range of factors, which are often also beyond the individual's control. Systems that rely on error-free performance are doomed to failure. Error prevention that relies exclusively on discipline and training is also doomed to failure. And what he said, solutions to the problem of medical error primarily lie within the disciplines of psychology and human factors, and he set out proposals for error reduction that acknowledged human limitations and variability and rely more on changing the conditions of work than on training.
Okay, Sunil, can you tell us something about the science then of patient safety?
So if there's four areas I briefly discuss in terms of the science of patient safety. First, understanding how things go wrong, then improving healthcare processes and systems, then people create safety, and fourth thing, after an error. So first, understanding how things go wrong. So slips and lapses are errors of action and memory. Mistakes are errors of knowledge and planning. Errors can only be properly understood in context. Patient, task, individual, team, environment, organisational and institutional context factors may all influence incidents and accidents, and incidents may act as a window on the healthcare system. In terms of improving healthcare processes and systems, standardising and simplifying clinical processes is a powerful way of increasing reliability. Reducing reliance on human beings with decision support and technology increases reliability in standardised systems. Even in good systems, people need to anticipate hazards. Medication errors can be reduced by preventing error, by making errors more visible, and by planned limitation of harm from the remaining errors. And computerised prescribing reduces medication error, but is not a panacea. In terms of what the science and the research tells us about people and safety, people create safety. So patients and families can provide critical safety information and play a part in monitoring the safety of their own care. Expert clinicians learn to work confidently yet safely by anticipating and negotiating the hazards of both the disease and the organisation. A team that is working poorly multiplies the possibility of error. Teams that work well are safer than any one individual. Explicit daily plans and goals can enormously increase reliability of care provided to patients, and using briefing and checklists in the operating theatre reduces surgical complications and improves team performance. And finally, a few points about what the science says about after an error. Injured patients have been harmed by people they trusted, so their reactions can be especially intense. Injured patients may suffer a second trauma if the incident is badly handled. Providing an explanation, apology, financial and other support, and acting to prevent recurrence are critical to maintaining trust. Making an error that harms the patient is one of the most stressful experiences in a clinical career, and open disclosure and support are critical for patients, families and staff.
So what can the NHS learn from the Institute of Healthcare Improvement?
So the Institute of Healthcare Improvement in the United States saved over 100,000 lives in the 18 months to June 2006 by 6 interventions in over 2,000 hospitals. And the 6 interventions were: deploy rapid response teams at the first sign of patient decline, deliver reliable evidence-based care for acute myocardial infarction to prevent deaths from heart attack, prevent adverse drug events by implementing medication reconciliation, prevent central line infections by implementing a series of interdependent, scientifically grounded steps, prevent surgical site infections by reliably delivering the correct perioperative antibiotics at the proper time, and the 6th step was prevent ventilation-associated pneumonia by implementing a series of interdependent, scientifically grounded steps. And once the Institute of Healthcare Improvement made those improvements, it then launched its 5 Million Lives campaign in 2008, which was tried to prevent harm. And the things it concentrated in that campaign were things like prevent pressure ulcers by reliably using science-based guidelines for their prevention, reduce methicillin-resistant Staph aureus infection by reliably implementing scientifically proven infection control practices, prevent harm from high-alert medications, starting with a focus on anticoagulants, sedatives, narcotics and insulin, reduce surgical complications by reliably implementing all of the changes in care recommended by the Surgical Care Improvement Project, deliver reliable evidence-based care for congestive heart failure to reduce readmissions, and finally get boards on board by defining and spreading the best known leverage processes for hospital boards of directors so that they become far more effective in accelerating organisational progress towards safe care.
And then we've had the Berwick report. What problems were identified by the Berwick report into patient safety in the NHS in August 2013?
So the Berwick report identified 7 main problems. 1. Patient safety problems exist throughout the NHS, as they do with every other healthcare system in the world. NHS staff are not to blame. In the vast majority of cases, it is the systems, procedures, conditions, environment and constraints they face that lead to patient safety problems. The third problem identified was incorrect priorities do damage. Other goals are important, but the central focus must always be on patients. 4. In some instances, including mid-Staffordshire, clear warning signals abounded and were not heeded, especially the voices of patients and carers. 5. When responsibility is diffused, it is not clearly owned. With too many in charge, no one is. 6. Improvement requires a system of support. The NHS needs a considered, resourced and driven agenda of capability building in order to deliver continuous improvement. And the 7th problem identified by the Berwick report was fear is toxic to both safety and improvement.
So in light of that, what was the advice of the Berwick report?
So the Berwick report came up with 8 recommendations. Recognise with clarity and courage the need for wide systemic change. Abandon blame as a tool. Reassert the primacy of working with patients and carers to set and achieve healthcare goals. Use quantitative targets with caution. Recognise that transparency is essential and expect and insist on it at all levels and with regard to all types of information. Ensure that responsibility for functions related to safety and improvement are vested clearly and simply. Give the people of the NHS top to bottom career-long help to learn, master and apply modern methods of quality control, quality improvement and quality planning, and finally, make sure pride and joy in work, not fear, infuse the NHS.
Thank you. So Sunil, what did the Berwick report say about how leadership behaviour affects patient safety?
So the Berwick report mentioned 14 leadership behaviours that increase risk and make healthcare less safe, and 14 leadership behaviours that reduce risk and make healthcare more safe. So the leadership behaviours that increase risk and make healthcare less safe are: blame staff even when they haven't been given the conditions for success; fail to focus on the patient, often signalling instead that targets and costs are centre stage; make bad news unwelcome, too often silencing it; not heed signals and warnings that things are amiss; muffle the voice of the patients, their carers and their families and largely ignore their complaints; fail to listen to staff; diffuse responsibility and disguise who is in charge; offer no systematic support for improvement capability; game data and goals; lead by rules and procedures alone in a disengaged way; apply sanctions to errors; create fearfulness amongst colleagues and staff; ignore the development of the next generation of leaders; and treat all problems as though they can be fixed with existing technologies or writing clearer procedures. And the leadership behaviours that reduce risk and make healthcare more safe, according to the Berwick report, are: abandon blame as a tool; constantly and consistently assert the primacy of safely meeting patients' and carers' needs; expect and insist upon transparency, welcoming warnings of problems; recognise that the most valuable information is about risks and things that have gone wrong; hear the patient voice at every level, even when the voice is a whisper; seek out and listen to colleagues and staff; expect and achieve cooperation without exception; give help to learn, master and apply modern improvement methods; use data accurately even when uncomfortable to support healthcare and continual improvement; and finally, lead by example through commitment, encouragement, compassion and a learning approach. And there's 4 others: maintain a clear, mature and open dialogue about risk; infuse pride and joy in work; help develop the leadership pipeline by providing support and work experiences to enable others to improve their own leadership capability. And the 14th leadership behaviour that reduces risk and makes healthcare more safe is recognise that some problems require technical action, but that others are complex and may require many innovative solutions involving all who have a stake in the problem.
Thank you very much. So in summary, significant improvements in patient safety in the NHS could save thousands of lives a year, prevent untold misery and save billions of pounds. There is a science of patient safety, so we know what to do. The NHS must place patient safety as its highest aim. It must engage, empower and hear patients and carers, and it must foster the growth and development of all its staff and embrace transparency in the service of accountability, trust and the growth of knowledge. Thank you for listening to this podcast, and we hope you'll listen to some of the other podcasts here at the South Essex GP Training website.